box. So now just coming on to the second presentation from nuclear, infranuclear to the supranuclear movement, Dr. PRIYADARSHINI MISHRA. She is a faculty at AIMS Bhubaneswar. Now she would present her cases or the presentation.
Good morning all. I have no financial interest in this presentation. So as Madam already pointed out, so we have an afferent system and an efferent system. The efferent system, what we usually clinically think of is nuclear and infranuclear. Madam has shown lots of interesting cases, how our diagnosis can be misinterpreted or how we can, so we all learn from our mistakes. So now I'll come to supranuclear part of that. So what is supranuclear? The higher centers that is controlling the ocular movement. Okay, that is cerebral cortex, the part of cerebral cortex, frontal eye field, posterior parietal cortex, middle temporal and medial superior temporal. Which middle temporal, the recognition movement. So these are mostly concerned. Then comes to our basal ganglia, the red one, basal ganglia. Then superior colliculus, thalamus, cerebellum and rest is brainstem centers. Mouse is not working. In brainstem structure we have lots of centers that are primarily concerned with these ocular movements. One is interstitial nucleus of Cajal. Another is medial longitudinal fasciculus. I will come to this one by one. Mesencephalic reticular formation, as we can see all this structure one by one. This is the brainstem, midbrain pons medulla along with this cerebellum. And posterior commissure, rostral interstitial nucleus of medial longitudinal fasciculus. Paramedian pontine reticular formation, PPRF. First I am showing the short form so that in later talks we will deal with the short forms. Dorsolateral pontine nucleus, although it is not visible here, better seen in axial view. Then we have vestibular nuclei and nucleus prepositus hypoglossi. So we have 6 systems, usually 6 ocular fixation system, vestibulo-ocular, optokinetic, smooth pursuit and vergence. So what is the role of ocular fixation system? It fixates the eye, and although what we know, any neural structures they become fatigue after any fixation, the signal went away. To avoid that, the eye has a microsaccadic refixation movement. Although this movement is not clinically appreciated, but there is microsaccadic refixation movements that continue to fixate this eye. If there is disorder in this infection, we can have nystagmus or we can have saccadic intrusion. If it is a slow movement, then it is nystagmus. If it is a rapid eye movement, then it will be saccadic intrusion. So after this ocular fixation, we will come to vestibulo-ocular system. When our head is rotated for a brief period, then we are focusing on a subject and we are moving our head for a brief period, then eye will be fixed to that object by this vestibular because it is for a brief period. The structures concerned are labyrinth, it is a part of inner ear and it contains this semicircular canal 3, anterior, superior and posterior and auricular and saccule. Cranial nerve 8th and 6th are involved. Cerebellum that fine tunes this vestibular and although the otolith. So what lesion can occurs to this lower pons and medulla? If affected by any lesion, they are going to affect this vestibular system. How we test that in clinical? We assess, that is a head impulse test. 20 degree we rotate the head suddenly and we see how the eye is moving in opposite direction properly or not. That is head impulse test. Then we see whether there is any nystagmus or not. And also we want to know where there is skew. So what happens in nystagmus? There can be peripheral vestibular system and there can be central vestibular system. How will you differentiate? In central vestibular system, usually the nystagmus is a vertical or torsional one and it is not suppressed by fixation. Whereas in peripheral vestibular lesion, it is usually the horizontal nystagmus and that is increased in the first phase. I will show a video after this and there will be abnormal head impulse test. What I told, rotate the head suddenly 20 degree and see how the moving is. If it is malfunctioning, that eye will not focus to that point, it will go to a point, then refixation circuits, catch-up circuits will be there. And in peripheral system there will be no skew deviation. So now what is skew deviation? It is a vertical misalignment of eye due to asymmetric otolithic input. It is a vertical asymmetry. So in what case clinical we see other vertical asymmetry? Fourth nerve palsy. So how we are going to differentiate these two, fourth nerve palsy and third nerve skew? So what we know in fourth nerve palsy, supply superior oblique. So when it is there is a palsy, so it will be intorsion will not be there, that means eye will be extorted. But what happens in skew, the hypertrophic eye will be intorsion of the hypertrophic eye. This is the like this, if we tilt our head one side, the higher end will be come down hypertrophic and the lower side will be, this is all to maintain a fixation point. But in skew, this is the one differentiation point, and as it is vestibular mediated, so when the patient lie down in supine position, it will improve, the nystagmus will improve and vertical deviation will improve, but in fourth nerve palsy vertical deviation will not improve. So this is a peripheral vestibular nucleus peripheral nystitis. As I have pointed out, only to show you nystagmus, that is right beating nystagmus. Beating means rightwards more, the first point is towards right, and it is following the Alexander's law, that is it is increasing in direction of the speed, first component, that is Alexander's law. So what I just 1 minute I want to again refocus, what was that? Hints test, head impulse, nystagmus and testing for screw. If these are positive, all three, then usually this is a peripheral component. So no need to do MRI. The stroke and other dangerous disease are usually excluded, but all three you need to rule out. Then come to optokinetic system. Now I talked what for a brief period. Then when it is a sustained head rotation, either the object is moving or the head is sustained moving. Because vestibular apparatus, there are cilia. Cilia are deflected. It stimulates the eighth nerve, so it fades away within a short time. But optokinetic system, it maintains then. So what happens optokinetic system? It can be tested clinically with a drum, optokinetic nystagmus. When we move eye in one direction, there will be contraversive, involuntary reflexive saccade. So this is optokinetic system. Now coming to the most common, that is clinically is and very much tested in brain central neurological disorders, is the saccadic system. It can be volitional and can be reflexive. So there is a horizontal pathway and there is a vertical pathway. Why I am going to little bit this pathway? Because it is usually to understand, otherwise we can interpret the cases. So horizontal system, our frontal eye field is affected. Then we come to basal ganglia, and whenever frontal eye is affecting, it is stimulating the contralateral PPRF, which is a horizontal gaze coordinator. So this is the contralateral side. There are burst cell, and to inhibit that there are omnipose cells. So I will be moved to this direction, and again there will be a pulse component that will start, and there will be a hold component. That means it will keeps the object holding in that eccentric gaze. It is called pulse step, and to integrate this pulse step we have neural coordinator, integrator, that is nucleus prepositus hypoglossi. So this is our vertical system. Again just remember two names, that is rostral interstitial and nucleus, and this is also the pathway system. This vestibular and saccadic, they meet at one point. So this is saccadic system for a vertical saccade pathway. Here it is the rostral interstitial and the neural integrator, the interstitial nucleus of Cahal. Then little bit about what we clinically see the most, that is interneuron. What are interneuron? Between these two nucleus, they are the communicating neurons, that is called interneuron. One is PPRF, most common for ophthalmology point of view, and one is MLF. So PPRF is the horizontal gate sensor that is located ventral to. We can see PPRF is here. This is the sixth nerve, that is pons, and just near this is PPRF. So this is one interneuron, and usually when the sixth nerve and PPRF is commonly affected, so this will be along with the abduction palsy due to sixth nerve, there will also the gaze center to this side will be affected, single side. And what is MLF? As we can see, this is the band, this is MLF. What it communicating? This is sixth nerve, ipsilateral third nerve to contralateral sixth nerve. This is MLF. So what happens, why these interneurons are very important? Clinically, these are the cases that first come to ophthalmologist, not to neurologist. So we should know these cases very well. So this is one. So before in the diagram also I am telling what suppose this structure is affected MLF. So what will, this is third nerve is affecting, so this eye adduction will be restricted. Always MLF that side it will be NMF. Suppose it is right side, so right internuclear ophthalmoplegia it will be told, and left side whatever the while abduction there will be nystagmus. So this side adduction will be restricted and this side there will be abducting nystagmus. We can see this from these cases. As we can see, this is a young male, just keep looking at the eye, how it is reacting. Whenever we are testing the gaze, the left eye adduction is restricted, and note the right eye. The right eye abduction is complete, but look at the nystagmus, that is, so this abducting nystagmus will be there. So this is called internuclear ophthalmoplegia. And what happens if when we are, as I told, one side sixth nerve and PPRF will be affected, then abduction palsy and gaze both will go. What happens when one side MLF and one side PPRF both will go? Then that is called 1.5 syndrome. That means only one abduction will be left one eye will be totally frozen and other side will be adduction. So we can test clinically how volutional, we can test ask the patient to look at 2 points rapidly, and we can see what is the velocity, what is the accuracy, that is looking at the point accurately. If not, that is hypometric or hypermetric. Hypometric in senile age group may be normal, but hypermetric is never. So if it is hypermetric, patient will overshoot and then come back. So, and we can see is there are any involuntary slackers. If saccadic pathway is already I have told, there will be saccadic intrusion. These are very high, rapid movements. So, latency, accuracy, conjugacy, all we clinically need for saccades. And as we know, whenever we are going to ICU patients, whenever there is a lesion in frontal eye field, it indicates the contralateral saccade will be initiated, but now it is not happening. So eye will be conjugated, deviate to that side. But if it is a seizure like irritating lesion, then that will be deviated to contralateral side. Then smooth pursuit, as we track a smooth object of interest, smooth pursuit is little bit less understood till now as a saccadic pathway, but most probably the M ganglion cells and the magnocellular layer of lateral geniculate body to that middle temporal area is mostly involved, and from that it will be come to our dorsolateral pontine nuclei will be affected, and vestibular and abducens will be. So it will be a smooth pursuit and tracking system. So last is the Vergen system. Vergens I will not go to detail. Convergence and divergence is basic part of strabismus workup. So Vergens, and just to little bit convergence, one important is dorsal midbrain syndrome. All of you should know dorsal midbrain syndrome. It is a part of convergence insufficiency, is the part of this syndrome, and there can also be sometimes divergence insufficiency. And gaze preference I have already told, irritating lesion. and sometimes eye due to can be tonic downward definition, and sometimes some drugs can cause side effects, and it is called oculogyric crisis. I am just finishing my talk. So this is last two video I am just showing. As we can see, this is one, this is not a complete assessment, but here we can see this lesion is here in brainstem. So if you are seeing any brainstem lesion, try to record carefully what is that movement is being produced. Sometimes it may not give you a complete picture. Dorsal midbrain syndrome, it is a incomplete one, but always try to look for that what is the lesion, so it will point out where the, this is also another horizontal gaze palsy. You can see there is a lesion, small lesion, these are very small lesions in brainstem.
फॉलो करते जाइए हम वाला ले
This by Kumudini madam, this photo and video Kumudini madam has taken. As you can see, this is a horizontal gaze palsy. So thank you all of you. Hope this talk will just create interest among you to little bit about the supranuclear pathway. Okay, thank you all of you.